Okay, thank you, Celia. And I have to say, it's great to be here a year on. I think the year feels as if it's gone very, very quickly. Before we were last in QE2 talking about, or I suppose launching this programme 1 year ago. It's been great to hear about the successes that organisations have had, the Wave 1 sites. I think great also that we can now, be here today and hear the stories being told from essentially over 200 quality improvement leaders. I think one thing for me that I've really noticed is a change in language. So I can remember back in Leeds, the Royal Leeds Armoury, when we started talking about statistical process control and driver diagrams and PDSA cycles, and I could see some people were kind of glazing over with this new language that was being introduced to them. But actually to hear, today, going to some of the breakout sessions, it's become part of people's language, it's become part of people's description around the tools that are used to enable quality improvement to thrive and to sustain. And that's a really good thing to hear. And I think it's also a privilege for me personally now to launch Wave 2 officially. Officially launches on the 1st of April, but to really kind of set out the programme for the coming year as we do move into Wave 2. I think it's probably worth saying right from the very beginning that maternity care in England is of high quality. Let's not forget the quality of care that is delivered in the country. I think there is absolutely no question from our perspective as a programme that the commitment and the compassion in maternity neonatal services that we've seen is excellent. Nobody comes to work to do a bad job. Everyone is under huge pressures behind the scenes on an organisational basis and on a unit basis. And I think the other thing probably to add is this isn't a new piece of work. This shouldn't be an additional piece of work, but really the tools and the skills and the behaviours to do what needs to be done around improving the quality and safety of care. So our ambition to revisit this. So initially we started out as a 3-year programme. It may well be 3 years, it may well be longer, but essentially by March 2020, we are really still looking to significantly improve the capability and capacity of improvement in the system. So to skill up and to build those connections across clinicians and managers around how to do some of this work, which is really the key focus of the work, not what necessarily needs doing, but how to do it effectively and sustainably. We're also still really keen to build a very good picture across England about what safety culture looks like in maternity and neonatal teams, recognising that there's been some issues and delays to get the first culture survey underway, but we now have the date of the 19th of March when that will be happening for Wave 1 sites and shortly followed in May or June for Wave 2 sites as part of their diagnostic work. So really keen to get that piece of work underway because I know there's been lots of you waiting for that to be undertaken. I think the other thing is to really understand some of the kind of priorities and gaps in the services at the moment. So where could we improve? What are we doing well, but equally, where could we improve? And I think building up that picture across the country is going to be quite important, as well as trying to understand how is that being reflected in your own improvement plans that you're developing back within your organisations. And I think ultimately there's something about making a significant improvement to the service that's provided locally, both in terms of quality of service, but probably importantly around the safety of that service too. And for there to be some element of transparency around how we share some of the learning, but also some of the data as well. So that's certainly our ambition. So ultimately to create conditions within the system that enable a culture of safety to thrive, but also that we create a national learning system where we share and learn from each other in an ongoing, continuous fashion. Tony talked about the aim of the programme this morning, just to really reiterate this. This is really key for us, I think, as a programme, and something that we started out with last year. And really with a focus on improving the outcomes and reducing the unwarranted variation in care that's provided, but also something quite key about the experience of staff and mothers and families in the care that they receive. So Tony talks very much this morning about what we've learned over the last year, and I think it's really interesting to hear that talk given in more general terms, also to hear about the learning that Wave 1 sites have been sharing throughout the breakout sessions. We've learned some stuff too as a programme, and I think one of the things that we're quite keen and have been quite keen to do was to revisit and relook at our driver diagram. And I think some of what was in this now has been alluded to this morning in terms of us having much more focus on 5 key clinical interventions that will run as a golden thread throughout the collaborative and throughout the learning systems of the work that we do. But there's also something about not losing some of the focus on the areas that underpin or should underpin some of these clinical interventions. So we have the big 5 there in terms of the primary drivers, but let's not forget the secondary drivers. We're still very keen to look at safety culture and use culture improvement to underpin how some of these 5 clinical interventions are delivered. Likewise, are we really sure that we have the right pathways in place, the right systems and the right processes to support those clinical interventions? So again, there'll be some work to look at how we can underpin from that perspective. We really want mothers, families and staff to be at the core of all of this work. So again, how can we meaningfully work with mothers and families to co-design work that leads to improvement through these 5 clinical areas? I think it's been mentioned on a few of the breakout sessions, but also referred to this morning. But let's also identify good stuff, so good work that's happening. How can we learn from that as well as learning from harm? Okay, and I think it resonates in a much more positive light, learning from some of the excellence that clearly is around the country that we need to tap into, access and share much more effectively. And clearly there's something about the interventions themselves. So I think Wave 2 will have much more focus on working within these 5 clinical areas than perhaps Wave 1 has done during the first year. And if we just look at some of those areas, as I say, some real focus on the culture, real focus on the systems and the pathways, learning from excellence, the experience and the clinical excellence itself. Now, one thing that we've been working on over the last, I suppose, few months is trying to develop the change packages that support each of these 5 clinical areas. So it would be very much about some of that work already being done. Now, I've been to a few sessions earlier on today where I think some teams were describing developing their driver diagrams for the work that they've identified locally, and then starting to think through what some of those ideas will be and those change concepts might be. So I think we've tried to do some of that work up front for Wave 2. So I think there'll be a process of trying to understand which one of those 5 Wave 2 sites will invariably work on as part of the diagnostic phase of work, but then to give you some of the ideas and the suggested changes that you can go away and test. So I think we're taking out some of the pain that I think the Wave 1 sites clearly articulated in some of the sessions. So just as an example, here's one taken from the reducing smoking, smoking cessation primary drivers. So some of the things here are some ideas about areas that might be tested in terms of PDSA cycles, and equally some of the things that might be measured. So this information will be supplied very early on in the process for Wave 2 sites. That's certainly some of our learning. And I want to draw everyone's attention to the framework for clinical excellence that I think really has sort of run through all of the work that we've been doing. So this is a framework that was developed by the Institute of Healthcare Improvement. It's describing 2 parts of the system and really is the foundation for safety improvement. And I think many individuals are subscribing to this more and more. And it describes things that need to be done to create a system of learning where we learn from things that go well as learn from harm, but also how we create the conditions for a culture of safety. And I think this framework will again run as a thread through lots of the secondary drivers, and we wish that to continue working with Wave 2 sites as we move forward. So I think there will be a focus on accountability in the system, there will be a focus on teamwork and communication, a focus on psychological safety. So do we actually feel as if we can raise concerns within our organisation without fear? And equally about the learning system itself. How can we be more transparent? What is the role of leadership? How can that effectively enable a system of safety and of learning? How can we develop reliable systems and pathways within the care? So just some examples of some of the areas that we'll be focusing on more in Wave 2. So just to remind mainly the Wave 2, Wave 3 sites that we haven't seen for a year. So it looks like a fairly complicated slide, but essentially I just want to make sure that I say something about where the programme sits and some of the work and some of the kind of groups that sit behind this programme. So we are very much supportive of the ambition, or supporting the ambition of the Maternity Transformation Programme that NHS England leads on nationally. We are part of the work stream 2, which is a safety work stream within that programme. So there's a bigger piece of work happening out there in the system to support maternity, neonatal transformation of care. So this is a big part of making that happen on the ground. We have a very small central programme team. We have an advisory faculty that I think Tony referred to this morning, and a steering group that kind of gives us some strategic guidance. But really some of this work is about the individuals that organisations nominate as their improvement leads. So these are the obstetricians, neonatologists, midwives, neonatal nurses and managers that are put forward to represent their organisation as improvement leads and come to our learning sets to be trained in QI methodology. And one thing probably to say at this stage is that I think we never intended for the improvement leads to necessarily be the most senior individuals representing the organisation. So these leads are very much about people who can do work, who can cajole and bully and coerce their colleagues back at ranch to actually do some of this work, who can coordinate some of the project teams, but have the capacity and are supported to do this. I think that's certainly our idea. I'll talk a bit more about the national learning sets and the national learning events in later slides, but very much wanting you to see the overarching picture. So it is a wider programme, and that level of support is reflected here. So again, just to kind of recap on how the collaborative is structured, we launched in Wave 1 in February 2017. Wave 2, we have 44 organisations joining. So I think this year we'll be covering 2/3 of provider organisations in country. So that's quite a significant number. The 44 organisations that will be joining in Wave 2 will be supported at national and local level. And we see very much Wave 1 and Wave 2 organisations, probably more Wave 1 at this stage, and this may already have happened, starting to be in demand to share their stories and share their experiences of the improvement journeys that they've been on, either through maternity clinical networks, patient safety collaboratives, or indeed some of the learning systems that are starting to be developed across the country. And Wave 3, final wave of this phase of the programme, will focus on the remaining 46 organisations that will join us in April 2019. Now, Wave 2 is going to be structured slightly differently, I think, and probably just to clarify that the programme has really two arms. Okay, there's an arm that is focusing very specific support to organisations within an active wave. But there's a growing arm, the other arm, which is about the developing learning systems. These were formerly called communities of practice, but the learning systems that were out there and working with trusts, clinical networks, and local maternity systems. Okay. So I think, obviously, we were very aware in the very early days of the programme that while we may be working very much with individual organisations as part of an active wave, there were questions about, well, what happens if we're in wave 2? What happens if we're in wave 3? And equally, how do wave 1 share some of the learning that they've developed over the last year and indeed in the future? So I think the community of practice, formerly known as, and the learning systems kind of addressed some of this need, where not only wave 1, 2 and 3 sites can come together to share learning, but equally that there can be some work that occurs at system level. And I think, as we know, certainly some of the work in the change packages that we're going to be sharing during wave 2 do lend themselves to an organisation focus of work, but some work lends itself more to organisations working together. So smoking cessation may be one of those areas that has benefit of occurring at system level. And just as a reminder, each wave is structured as such. So every year we will have a national learning event such as this, where every wave is invited to come and hear from the last wave that worked on the improvement. So we will have another event next March. In fact, we might reschedule for the summer, I think, this time. But certainly we'll have another learning event where wave 2 will share some of their learning. And then for those organisations in the active wave, we have 9 days or 3 lots of 3 days of training. But it's not just about quality improvement training. There's a great opportunity for networking and for peer support, essentially, around some really challenging problems. Trying to look at what the potential change ideas could be to go back and test to address some of those problems. I think wave 2, we're also going to have a greater focus on developing some of the executive sponsor support that's provided to the sites. I think we feel as if we slightly missed a trick in the first wave in terms of, the executive sponsors being the people that can unblock the blockages that there were in terms of your work and how that moves forward and how that's supported. So I think we want to allocate a bigger slice of the resource to developing the executives to support wave 2 sites and teams to improve faster and better. So that's something that we're going to be doing much more for wave 2, and inviting the exec teams to each of the learning sets on the last day. The other thing that's going to change slightly is that I think we set out wave 1 with the commitment that the improvement managers would visit on I think originally it was every month, but then it turned into every 6 to 8 weeks. I think this time we want to look at this more as a kind of tailored support. So I think we'll work on the level of support very much on an individual basis. So clearly where some teams need more support, we will provide that on a face-to-face basis. Where teams are okay and doing well, maybe they don't need face-to-face, but actually there's always a phone that they can contact one of the improvement managers to provide support. So I think we're going to tailor-make the improvement managers' support much more. And of course, the local learning systems, we have 21 at the moment that are being developed. We see these very much as facilitating up to quarterly local learning meetings, and I know that some of them have already taken place across the country. So the local learning systems are supported by colleagues from the patient safety collaboratives, which is really fantastic to have them helping facilitate these groups and organising and coordinating some of the activities. But ideally supported by all our stakeholders in the system. So that goes without saying, our maternity clinical network friends and operational delivery network colleagues too. And I think the learning systems probably will be the legacy of this programme in the future. These will be the forums where local concerns and issues are addressed among a group of organisations within a local maternity system. So I think there's a natural move that some of this work will shift within these systems as time moves on. We started out with 21 local maternity systems. I see that number increasing as over the coming year. And I think these collaborative learning systems do need to be seen as the local improvement communities, so that they primarily support the national driver diagram, but equally they also provide support or enable support for system-level improvement. And as a reminder, the local learning systems aren't just for a current wave, these are for all waves and all organisations. And equally, we're really keen to have multi-professional groups as part of these learning systems, as indeed mothers and their families. So I think we need to clarify our message much more around the local learning systems, and it's something that we will be doing fairly shortly by providing an updated paper and updated terms of reference. But feel very much that these forums are for local improvement, your improvement to be shared and to thrive. We see the local learning systems as providing an opportunity to all stakeholders to work collaboratively. Equally, an opportunity to improve QI capability. I think what's been quite clear from the first wave is that as wave 1 sites start to talk about new ways to approach improvement, actually those messages are filtering through to colleagues that aren't part of wave 1. So we're hearing wave 2 sites and wave 3 sites starting to echo some of this language and some of this thinking, which I think is fantastic, and it's kind of how it should be, really. So you're influencing, or wave 1 sites, influencing in many different ways, influencing the system in many different ways, and pray that continue within the learning systems themselves. I think there's a great opportunity here to also support the work of the LMSs. So these aren't about duplicating anything that's being done, but actually about supporting a really big agenda and a really big piece of work that's happening within the system anyway. And also a forum for sustainable solutions to continue around improvement. And I think certainly through discussions that we've had up and down the country, there's there have been some concerns around these, and certainly what we don't see the learning systems as being is having a greater emphasis on strategy than delivery, or that there being a focus on performance rather than improvement. So they're there to complement and support, but actually there are other structures in the systems to deal with strategy and performance. So the level of support that our team will provide, or the collaborative will provide to the active waves, is fairly consistent with what was provided in wave 1. So certainly the wave 2 sites will be invited to join 9 days of training, so 3 learning sets throughout the year. Clearly, as I mentioned before, we will have a national learning event in March next year, or even later. We will tailor the site visits that we provide based on your need and your ambition, and be much more responsive to that in wave 2. Clearly, the learning system meetings will continue to be facilitated by the patient safety collaboratives as we move forward in the new financial year. There's still a big focus on trying to increase the improvement capability and develop that further throughout wave 2 and beyond. Clearly, there will be resources that we will want to share with wave 2 and other wave sites, which will be much more readily accessible for next year. Still very keen to focus on measurement for improvement that underpins the work as we move forward. So I think much more focus on that for next year. And clearly, I think as I've picked up on a number of the breakout sessions, access to the Life QI system that the patient safety collaboratives provide will be equally offered to wave 2 sites to manage projects on a day-to-day basis. So that's the kind of level of support that will be provided in wave 2. And I just wanted to sort of take you through what this actually means, what this actually looks like, and what the activity of an individual unit per wave will be doing. And I think you've obviously picked up on, you would have picked up on some of that through the breakout sessions. So we've kind of split the work of a wave in 3 phases. So something about the diagnostic piece, so understanding the current service, something about the testing, and something about the refining and the scale up. And see very much that the diagnostic phase is about you understanding the service that you provide. So you're examining the care pathways, you will be looking at good practice and identifying that, and there will be good practice, looking at your data, understanding your culture surveys, and I can probably promise on this occasion that Wave 2 sites will have a culture survey during their diagnostic phase. Looking at your local priorities and looking at where there may be some gaps in the service that you're providing. We'll be asking Wave 2 sites to choose one of the primary drivers or one or more of the primary drivers as a result of looking at where some of the gaps might be or where some of the opportunities for improvement might be within their teams and within their services. Really doing some focused work on identifying the people that need to be involved within the project teams and engaging the leaders in this work, which is going to be absolutely key. And I think there still is an expectation that this is pulled into an improvement plan. For the testing phase, I think that's very much about refining your ambition, really understanding the aims of each of the projects of what needs to be done, engaging with and setting up the project teams. So I think even if you choose one primary driver, so one of those kind of clinical interventions, there will be a number of projects underneath that will support that work to happen. Using the change package that NHS Improvement gives you to test out some ideas about how you might improve, and then commencing the Plan, Do, Study, Act cycles of change, and clearly a process of collecting measures and continuing to test. And the last phase of the wave really is about refining that learning, so those PDSA cycles, and extracting and sharing the learning that you have from the process of testing. And there will be lots of opportunity to learn from other ways and learn from the learning systems, and for you to continue to monitor and learn yourselves and ideally sustain improvements. So I think this is how we've kind of described the 3 phases of a wave, but we will support Wave 2 sites to help manage and undertake this. And ultimately, what does that all mean? I think there is something about improvement teams and individuals finding the time to do this, and that sounds a very easy thing to do, but it is quite challenging. But we do need to find the time to do this. This is your improvement journey. I think there's also something about really understanding your current service and what it delivers, and its strengths to share and its weaknesses to improve. I think there's also something about more focus perhaps on understanding the user's perspective of your service. So what does it mean? What does your service mean to mothers and families? And are there any opportunities for improvement in those specific areas? I think it will be good to define the priorities and ambitions of each of the teams and understand what the measurable aims are of the projects that our works through. I think equally there's something about engaging the maternity service, and we've seen some really good successes at this, but equally we've seen some teams struggle to do this, are still continuing to try to do this. But ultimately there's an improvement role for everybody within the team. And I think a lot more focus on working with the clinical evidence, i.e. the what needs to be done, but really trying to understand to a greater degree about how to implement good clinical practice, evidence-based practice, reliably. Start small and undertake improvement through testing change ideas using the PDSA cycle, and an expectation to report on progress monthly, so others will be interested in your learning. And I think finally for me to realise that while there are quick wins, There are no improvement solutions until the solutions have been tested, measured and refined. So on that note, I'd like to thank you again. I've given you the dates for the learning sets for Wave 2 that you might want to jot down. We'll clearly communicate these to teams, and wish you well, and happy to take any questions. So thank you.
Thank you very much indeed, Phil. Now we've got the opportunity to pick up questions from GLISA or to take questions from the floor. Can we see if there are things that have come up on GLISA from this? Okay, so the top of the list there, Phil. What involvement have women and families had on the national platform in developing this collaborative?
Okay, so we have a steering group that I referred to earlier on, and on that steering group we have a mother who gives us some input and some steer, but I think there's more that we need to do as a collaborative central team to canvass opinion and challenge and thoughts on how we might move forward. And some of that, I think, is about what's inherent in the design of the collaborative, but equally some of that is about challenge to what more could we be doing in supporting teams who are working on improvement. So I think, you know, I mean, we've got more work to do on that, absolutely, and I think it's something that we're keen to focus on next year.
Okay, I think that's fair enough. Now the next question is quite an interesting one. It's what are the results of Wave 1? Are you more successful if you employ a clinical lead to drive the improvement initiatives forward? Now, my understanding is Wave 1 was very much what people wanted to do locally in terms of improving the quality of care for their patients. So how would you pick up that question about the results?
So I think Wave 1 has been some of Wave 1 has been around grounding some of the kind of improvement methodology within teams, and actually it's been quite a journey for not only Wave 1 teams but also the programme itself. So I think there's learning from Wave 1 in terms of how we measure things more effectively, how we're much more consistent with the areas that we're working on, and which we're, you know, ideally planning and are planning to manage within Wave 2. So I think the tangible results are much more varied, I think mainly because of the range of projects that we have in Wave 2. Now that is great, because ultimately what that means is there's lots of improvement activity happening across teams, and teams are focusing on things which are important to them. It makes it slightly more challenging from a national perspective in terms of aggregating some of those returns to say, you know, how much difference have we made in smoking cessation? How much difference have we made collectively in terms of earlier recognition of deterioration? So I suppose our focus has changed, but actually at the same time, while we're encouraging teams to work on, you know, a variety of different improvements that you guys feel is important locally, nationally, I think we're trying to refocus our attention on doing fewer things better. So I think that's going to be the focus for Wave 2 moving forward.
Okay, and I'm just going to take one more question now, and as I say, I promise that we will take the others away. So, crunchy one here for you. What are the funding commitments for quality improvement in this going forward?
I'm not sure I can answer that question.
You can't. All right, in that case, you can pick up the other one. So what do you think? Do you think there's a collaborative that has a wider role in tackling issues that are challenging the safe running of our maternity services, things like recruitment and retention of midwives, obstetrics and nursing staff?
I mean, my experience of working in clinical improvement collaboratives is that they can tackle so much, but they can't tackle everything. And I think there's work underway in the system through the various bodies that are looking at things such as, and particularly the Maternity Transformation Programme, as in mind, is looking at some of the slightly more challenging issues around workforce. Now, while I don't see workforce directly as being a piece of work that we have a lot of influence over in terms of the collaborative, and indeed should we, Actually, it is something that we need to align to and learn from and understand and ideally be part of, because clearly these are all areas that impact how improvement can be delivered ultimately. So I think for me, this is still about us improving our focus on the areas that we're going to work on, because we believe that we have some sphere of influence and control, but ultimately we are part of a wider system looking at some of these much more big, hairy problems in the system.
Okay, thank you. Can people join me in thanking Phil? Thanks very much indeed.